Спасибо. Я тогда жду ссылочки. Спасибо большое. Dear colleagues, good day. Hope you are doing well. Let's start our lectures. My name is Dr. Anna Sulima. I am professor of the Department of Obstetric and Gynecology #1 of our medical academy. Today we talk about one of the severe complication in pregnancy, in my opinion. This is hypertensive disorders during pregnancy. Let's start our lecture. The hypertension in pregnancy complicates near 6 to 8% of pregnancies. At 70% of cases, we have preeclampsia and eclampsia during pregnancy. At 30%, we have chronic hypertension. One of the more severe complications of hypertensive disorders is eclampsia. Its incidence is 0.05%. It's good because it's a very severe complications. At 20%, women with hypertension in pregnancy have maternal death. It's one of the causes of preterm birth, and nowadays the etiology of this pathology is unknown. What is risk factors of hypertension in pregnancy? It's a young age. The risk of hypertension increased in young female. In case of preemie gravida, multiple pregnancies, twins or triplets, also this is a risk factor of hypertension in pregnancy. Previous hypertension or hypertensive disorders in a previous pregnancies. Also extragenital pathology, for example, renal disease or collagen vascular disease. How to measure blood pressure in a pregnant woman? I told you about some rules of measurement of blood pressure during pregnancy. Automated machines not recommended for the blood pressure measurement in a pregnancy, unless calibrated against a mercury sphygmomanometer in the individual patient. Appropriate sized cuff. It's very important. Woman should sit for 2-3 minutes with feet supported after coming to the doctor's cabinet. It's very important, I pay your attention, that measure should doing at both arms during the first visit. And also you should write in a case history to measurement of arterial blood. Palpate systolic and go 20 millimeters higher. Deflate slowly 2 millimeters every second. Use Korotkov 5000. If 5000 is absent, you should use 4, but in the majority of cases, please use 5000 of Korotkov. Repeated measures may be required. Ambulatory monitoring useful for such wide-caused hypertension. The most common mistakes in measuring blood pressure in pregnant women. Use a cuff that does not fit the size of the shoulder, especially in obese women. Not enough time to adapt before the first measurement. As you know, the woman should sit near 2 or 3 minutes after coming to the doctor. Lack of control of the asymmetry of blood pressure on the right and left hands. Incorrect position of the body and arm on which measurements taken. Inaccuracy of instruments for measuring blood pressure. For example, you haven't a mercury sphygmomanometer and you use electronic device. Individual variability of blood pressure. Lack of necessary skills for continuous independent pressure measurement. What is a pregnant woman hypertensive? If systolic blood pressure is more than 140 and or diastolic 19 or higher on more than one occasion. In this case, we're talking about hypertension during pregnancy. Rise of more than 30 systolic or more than 15 diastolic. That's why the knowledge of prior blood pressure is very important for the doctor, and you need to ask about it in pregnant woman during her first visit to you. Not in itself diagnostic. Look for other problems. What is severe hypertension? The severe hypertension is more than 160 systolic and or diastolic more than 110. Requires admission and urgent medical aid. However, the diagnosis is more important than the actual level of blood pressure. What is classifications of hypertension in pregnancy? We have chronic hypertension, preeclampsia, eclampsia, preeclampsia superimposed upon chronic hypertension or renal disease, gestational hypertension. This is hypertension which is only during pregnancy, and transient hypertension only after pregnancy. What is chronic hypertension? The definition of chronic hypertension is it occurs before pregnancy. It's one of the obligatory conditions. Then before the 20th week of gestation, and in case of during pregnancy and not resolved postpartum. What is gestational hypertension? Gestational hypertensions, when you are registered systolic more than 140, diastolic more than 90, no proteinuria, and in 25% of gestational hypertension, the woman may have the development of preeclampsia, one of the complications of gestational hypertension. Diagnosis of gestational hypertension. Detected for first time after mid-pregnancy. There is no proteinuria only until a more specific diagnosis can be assigned postpartum. If preeclampsia does not develop and blood pressure returns to normal by 12 weeks postpartum, diagnosis is transient hypertension. Blood pressure remains high postpartum. Diagnosis is chronic hypertension. Proteinuria develops preeclampsia is diagnosed. The incidence of preeclampsia is 25%. What is preeclampsia? Preeclampsia may occur after 20th week, earlier maybe in case of trophoblastic disease, increased blood pressure, gestational blood pressure elevation with proteinuria. Edema is not part of this definition. Diagnosis of preeclampsia. Gestational hypertension, the systolic blood pressure more than 140, and diastolic blood pressure more than 90. Proteinuria is one of the obligatory signs of preeclampsia. It is defined as urinary excretion. What does it mean? 0.3 gram protein or greater in 24 hours, or double plus or greater on urine dip specimen. Preeclampsia. One of the main signs, of course, blood pressure. Measure of blood pressure should be in a sitting position with the proper diameter of the cuff at the level of the heart. Inferior vena cava compression by the gravid uterus while the patient is supine can, after reading substantially, leading to an underestimation of blood pressure. Blood pressures measured in the left lateral position similarly may yield falsely low values if the blood pressure is measured in the higher arm and the cuff is not maintained at heart level. Allow women to sit quietly for 5 to 2 minutes before measuring the blood pressure. Also record Korotkov 1, the first sound, and the fifth sound, the sound of disappearance, to denote systolic blood pressure and diastolic blood pressure respectively. In about 5% of women, an exaggerated gap exists between the first muffling and fifth disappearance Korotkov sound, with the fifth sound approaching 0. In this setting, record both the first and fifth sound. For example, 120, 80, 40, with 1001, 120, sound 4, 80, sound 5, 40. The classifications of preeclampsia, mild preeclampsia, and severe preeclampsia. Criteria for severe preeclampsia: one or more criteria. Blood pressure. Systolic blood pressure more than 150 or diastolic 110. Proteinuria more than 5 gram in 24 hours or lower triplet plus urine dip. oliguria, less than 400 milliliters in 24 hours. Also, clinical signs such as visual changes, headache, scotomata, mental status change. Also, pulmonary edema, epigastric pain usually indicates liver involvement. Also, the another criteria for severe preeclampsia, impaired liver function tests, thrombocytopenia, intrauterine growth restrictions of the fetus with or without abnormal Doppler assessment, and olighydramnios. Classifications of preeclampsia superimposed upon chronic hypertension. Hypertension and no proteinuria less than 20 weeks of pregnancy. In this case, the new onset of proteinuria after 20 weeks. This is preeclampsia upon chronic hypertension. Hypertension and proteinuria. Sudden increase in proteinuria. Sudden increase in blood pressure in women whose hypertension was well controlled. Thrombocytopenia, the platelet count less than 100,000 cells per milliliters cube, and increase in ALT or AST to abnormal levels. Preeclampsia ranges from mild to severe. Progression may be slow or rapid, hours to days, and even to weeks. For clinical management, preeclampsia should be overdiagnosed to prevent maternal and perinatal morbidity and mortality, primarily through timing of delivery. Pathophysiology of importance and distinguishing preeclampsia from chronic or gestational hypertension is that preeclampsia is more than hypertension. It's a systemic syndrome, and several of its non-hypertensive complications can be life-threatening when blood pressure elevations are quite mild. The maternal disease is characterized by vasospasm, activations of the coagulation system, perturbations in humoral and autocoid systems related to volume and blood pressure control. Oxidative stress and inflammatory-like responses, and pathologic changes that are ischemic in nature. The heart generally unaffected, cardiac decompensations in the presence of pre-existing heart disease. Kidney, renal lesions. It can be glomerular endotheliosis, renal blood flow decrease, hyperuricemia, proteinuria may appear late in clinical course, hypocalciuria, alterations in calcium regulatory hormones, impaired sodium excretion, and suppression of renin-angiotensin system. Coagulation system, thrombocytopenia, low antithrombin 3, and higher fibronectin. In case of impairment of liver, it leads to development of HELLP syndrome. What does it mean? H is hemolysis, E liver enzymes elevation, elevated ALT and ACT, and LP means low platelet count, a very severe complications of preeclampsia. Eclampsia is the convulsive phase of preeclampsia. Symptoms may include headache and visual disturbances, including blurred vision, scotoma, and rarely cortical blindness. Physical findings in preeclampsia: high blood pressure, more than 140 systolic blood pressure, and more than 90 diastolic blood pressure. Proteinuria, retinal vasospasm or retinal edema in the right upper quadrant, abdominal tenderness stems from liver swelling and capsular stretch. Edema. Edema of the arms and legs is often, in the majority of cases, I pay your attention. This is a normal physiological reaction to an increase in circulating blood volume and body weight during pregnancy. Using the presence of edema as the criterion for the diagnosis of preeclampsia often leads to overdiagnosis. In the diagnosis of preeclampsia, only suddenly appearance and or generalized edema can be a criteria of preeclampsia. Proteinuria. The diagnostic proteinuria, like a clinical criteria of preeclampsia, this is 0.3 or more than 0.3 gram per day or 0.3 or more than 0.3 gram or 1 plus in 2 servings taken at intervals of 4 hours. Moderate proteinuria is a protein level more than 0. gram per 24 hours or 0.3 grams per liter determined into 2 portions of urine taken at intervals of 4 hours or 1 plus value on the test strip. Severe proteinuria is a protein level more than 5 gram per day or more than 3 gram per liter in 2 portions of urine taken at intervals of 6 hours or a triplet plus value on a test strip. Symptoms of preeclampsia. Visual disturbances typical of preeclampsia are scintillations and scotomata. These disturbances are presumed to be due to cerebral vasospasm. Headache is of new onset and may be described as frontal throbbing or similar to migraine headache. However, no classic headache of preeclampsia exists. Epigastric pain is due to hepatic swelling and inflammation with stretch of their liver capsule. Pain may be of sudden onset. It may be constant and it may be moderate to severe in intensity. While mild lower extremity edema is common in normal pregnancy, a rapidly increasing or non-dependent edema may be a signal of developing preeclampsia. However, this signal theory remains controversial and recently has been removed from the most criteria for their diagnosis of preeclampsia. Rapid weight gain is a result of edema due to capillary leak as well as renal, sodium, and fluid retention. Brisk or hyperactive reflexes are common during pregnancy, but clonus is the sign of neuromuscular irritability that raises concern. Among pregnant women, 30% have some lower extremity edema as part of their normal pregnancy. However, sudden changes in dependent edema in non-dependent areas such as the face and hands, or rapid weight gain suggests a pathologic process and warrants further evaluation. Documentations of heart blood pressure before conception or before gestational week 20 favors a diagnosis of chronic hypertension, essential or secondary. Heart blood pressure presenting at mid-pregnancy, weeks 20 to 28, may be due to early preeclampsia, transient hypertension, or unrecognized chronic hypertension. The differential diagnosis with thrombotic thrombocytopenic purpura, hemolytic uremic syndrome, and acute fatty liver of pregnancy. High-risk patients presenting with normal blood pressure, hematocrit, hemoglobin, serum uric acid, If1 plus protein by routine urinalysis, clean catch, present obtained timed collections for protein and creatinine. Accurate dating and assessment of fetal growth, baseline sonogram at 25 to 28 weeks. Patients presenting with hypertension before gestation, week 20, same tests as described for high-risk patients presenting with normal blood pressure. Early baseline sonography for dating and fetal size. Patients presenting with hypertension after mild pregnancy, quantification of protein excretion, hemoglobin and hematocrit and platelet count, serum creatinine, uric acid and transaminase level, serum albumin, blood smear, and coagulation profile. Goal is to prevent eclampsia and other severe complications. Attempts to treat preeclampsia may be natriuresis or by lowering blood pressure may exacerbate pathologic changes. Palliate maternal condition to allow fetal maturation and cervical ripening. The treatment of preeclampsia consists, of course, evaluations of pregnant women. The main goals are early recognition of preeclampsia, observe progression both to prevent maternal complications and protect well-being of fetus. Early signs: blood pressure rises in late second and early third trimesters. Initial appearance of proteinuria is important. Often, hospitalization recommended with new onset preeclampsia to assess maternal and fetal conditions. Hospitalization for duration of pregnancy indicated for preterm onset of severe gestational hypertension or preeclampsia. Ambulatory management at home or a daycare unit may be considered with mild gestational hypertension or preeclampsia remote from term. Fetal assessment monitoring. Fetal heart auscultations, CTG continuously to stabilize blood pressure, Dopplerographic examination of the fetus, ultrasound, which include fathometry, measurement of amniotic fluid with amniotic index, and measurement of placenta. Nota bene, prevention of respiratory distress syndrome with gestational age up to 34 weeks, betamethasone 12 mg intramuscular with an interval of 24 hours. Dexamethasone may be used in the same regimen. Antepartum management of preeclampsia. Little to suggest therapy alters the underlying pathophysiology of preeclampsia. Restricted activity may be reasonable. Sodium restrictions and diuretic therapy appears to have no positive effect. Indication for delivery in preeclampsia. Maternal indication. Gestational age 38 weeks. Platelet count less than 100,000 cells. Progressive deterioration in liver and renal function. Suspected abruption placenta. Persistent severe headaches, visual changes, nausea, epigastric pain, or vomiting. Delivery should be based on maternal and fertile conditions as well as gestational age. Indications for delivery in preeclampsia fetal. Severe fetal growth restriction syndrome, non-reassuring fetal testing results, or in case of oligohydramnios. Delivery also should be based on maternal and fetal conditions as well as gestational age. The cure for preeclampsia is delivery. The cure is always beneficial for the mother Also, cesarean section might be needed. The care may be deleterious for their fetus. Route of delivery in case of preeclampsia. Vaginal delivery is preferable. Aggressive labor induction within 24 hours. Neuraxial, epidural, spinal, and combined spinal and epidural techniques offer advantages. Hydralazine, nitroglycerin, or labetalol may be used as pretreatment to reduce significant hypertension during delivery. Anticonvulsive therapy indicated to prevent recurrent convulsions in women with eclampsia or to prevent convulsions in women with preeclampsia. Parenteral magnesium sulfate reduces the frequency of eclampsia and maternal death. Prevention of convulsions. Introduce magnesium sulfate, 20 milliliters of 25% solution, intravenously slowly over 10 minutes, and 10 milliliters, 100 milliliters, through an infusomat at a rate of 2 grams per hour. Infusion. Only magnesium sulfate on a solution of natrium chloride or another crystalloid fluid. Then continue the infusion at a rate of 1 or 2 grams per hour. Usually, therapy continues for 24 hours after childbirth or after the last seizure in case of eclampsia. During infusion of magnesium sulfate, please control diuresis each hour, respiratory rate, oxygen saturations, and knee reflexes every 10 minutes for the first 2 hours, then every 30 minutes. Evaluations of serum magnesium levels, if possible, daily with continued infusion, more 24 hours. In case of intravenous administrations of magnesium sulfate, blood pressure measurement every 15 minutes, then heart rate, observations of breathing frequency, determinations of oxygen saturations, cardiac monitoring, ECG, knee reflexes, control urine output every hours. The antidote therapy in case of hypomagnemia, 2% of solution of calcium gluconate, 10 milliliters intravenously for 10 minutes. Such rules of 310. 2% calcium gluconate, 2 milliliters intravenously for 10 minutes. Treatment of acute severe hypertension in pregnancy. If you diagnosed systolic blood pressure more than 160 and or diastolic blood pressure more than 105 milliliters, please start intravenously of solution of magnesium sulfate. Parenteral labetalol is second-line drugs. Avoid in women with asthma. Oral nifedipine used with caution. Short-acting nifedipine is not approved by FDA for managing hypertension. Also, sodium nitroprusside may be used in rare cases. Avoid the use of atenolol because it can lead to bradycardia in the fetus or increased tone of the myometrium. Also, don't use angiotensin inhibitor conversion enzyme, angiotensin receptor blockers, spironolactone, and diuretics. Development of acute hypovolemia and dangerous side effects may occur. Eclampsia is a very severe complications of preeclampsia, has 4 periods or 4 stages. Preconvulsive period. The duration of this period 30 seconds, it's too small, believe me. Clinically, small twitching of the muscles of the face, the eyelids close, the corners of the mouth drop. Period of tonic convulsions. This period also duration 30 minutes. Tetanic contraction of the muscles of the whole body. The torso tenses. Breathing stops. The face turns blue. Period of clonic convulsions. Violent cramps, twitching of the muscles of the face, trunk and extremities, cramps gradually weakened, hoarse breathing appears, foam is released from the mouth, stand with blood due to a bite of the tongue. Seizure resolution period. Consciousness returns gradually. A woman does not remember anything that happened. Treatment should be begin immediately. You need to hospitalize a pregnant woman. The patient is laid on a flat surface in a position on the left side. Quickly release the airways, opening the mouth and pushing the lower jaw forward. Evacuate oral contents. With spontaneous breathing, enter the oropharyngeal duct and carry out inhalations with oxygen, applying another facial mask. In case of prolonged apnea, forced ventilations with a nasal-facial mask with a supply of 100% oxygen in the positive expiratory pressure mode. When seizures recur or coma persist, muscle relaxants are introduced and the patient is transferred to mechanical ventilations in moderate ventilations. In parallel, peripheral vein catheterizations and the introductions of anticonvulsant therapy and bladder catheterization. Counseling for future pregnancies. A risk of recurrent preeclampsia increasing. Preeclampsia before 30 weeks, the incidence of these complications is more than 40%. Multiparous compared with nulliparous or new father. Risk of recurrent preeclampsia may be substantially greater in African Americans. The more certain the diagnosis of preeclampsia, the lower the prevalence of remote cardiovascular disorders. Preeclampsia, eclampsia is subsequent pregnancies helps define future risk. Gestational hypertension in any pregnancy increases remote cardiovascular risk. This is all for today. Thank you for your attention. I wish you good luck. Stay safe and see you again on another lecture. Bye.